Hi, welcome to Solve ME's Advocacy Week 2024 Empower ME event. My name is Amanda Martin. I'm the engagement manager here at Solve, and I'm very excited to be the host for your Empower ME event this year. So what is our focus this year? We think of Empower ME is what I wish I would have known, right? So if you're 1 year, 5 years, 20 years into your disease and you look back and you say, "Oh, I wish I would have known X." That's what we really try to focus on with Empower ME. So we can help our community and the people especially that are just getting started, but also there are nuggets of wisdom that anyone anywhere on their journey can use. This year, we're focusing on how to build and work with your care team. And our theme is so that no family has to learn the hard way. I want to go ahead and jump right in and introduce our keynote speaker, Susannah Fox. And just so you know, if I'm looking off to the side, I'm not trying to be rude, but I've got my notes over here. And I want to make sure to be able to give her our full bios. So Susannah Fox is the author of Rebel Health, a field guide to the patient-led revolution in medical care, which helps people navigate health and technology. She served as the Chief Technology Officer for the U.S. Department of Health and Human Services, where she led an open data and innovation lab. Prior to that, she was the entrepreneur in residence at the Robert Wood Johnson Foundation and directed the health portfolio at the Pew Research Center's Internet Project. We are thrilled to have Susannah Fox be our keynote speaker today. So I'm going to go ahead and hand it off to Susannah.
Thank you so much. I am thrilled to be here. It's an honor to be with the Rebel Health Alliance for MECFS. And I wanted to begin by situating ourselves in the radical health movement history in the United States. When I started looking at the current radical health movements in order to try and translate what's going on to the C-suite of healthcare and to those who have not yet joined the revolution, I started by looking at our history. And I wanted to bring that forward because you are proudly stepping in to a history of people who have been left out of mainstream healthcare, who have self-organized to take care of each other and to gain attention for what we all should be aware of. So I'm going to start my timeline in the 1920s when an organization called Black Cross Nurses was formed to help people in the Jim Crow South get access to first aid and nutritional counseling. In 1935, Alcoholics Anonymous was the first peer-led program for substance use disorder that we now know is one of the most prevalent and successful ways for people to recover from alcohol use disorder. In 1948, at a mental hospital in New York State, people with serious mental illness gathered together in a clubhouse environment, in a room, to say, let's support each other. They were not being supported by clinicians and their communities, and so they turned to each other. And they eventually founded Fountain House, which is now a clubhouse model for people with serious mental illness, and they're having incredible success in that community. In 1971, the Black Panther Party saw that the US government was not collecting data about sickle cell anemia prevalence. And so they set out with their community health centers and community health workers to test Black people for sickle cell anemia. And it led to the first funding at NIH to study sickle cell. And we are now reaping the benefits of that activism by having incredible sickle cell treatments. In 1983, MHP Salud was founded with the idea that migrant workers are not getting the care that they need. And so MHP Salud was founded to create a a network of community health workers to help migrant workers. And in 1992, ACT UP was formed to respond, this might sound familiar, to a virus that was spreading through the land and through the world that people didn't understand. And the government's response was not enough. So people banded together to gather information and demand change very successfully for HIV/AIDS. And that playbook has served us well in the current environment. It was that playbook from ACT UP that a lot of MECFS activists have used and long COVID activists have used. And I actually ended my historical timeline there because the internet has transformed this patient-led, survivor-led, caregiver-led revolution by giving us access not only to information, but also to each other. The internet has erased the barriers of time and space and allowed us to connect with each other. Now, my book the subtitle of my book focuses on the patient-led revolution in medical care, but I did want to draw forward these words of survivor and caregiver. They are equally important to me. They're equally important in the research and in this revolution. My publisher basically said, you can't have everybody on the on the book title. But I'm so glad that this day and this advocacy week is bringing together this idea of survivorship and caregivership, because it is so incredibly important. I wrote this book to help people step into their power. I wrote this book so that people would see the work that they do in the revolution as powerful. I also wrote it so that leaders, policymakers, investors, people who run health systems, people who run health insurance companies would see that the patient-led revolution is for them too. It's their opportunity to understand the power of patients and survivors and caregivers and partner with us to learn about the radical health movements that are creating the tools and science that we all need and we are all learning from, and bring that into their work. And I will gently say to them, I'm an ambassador from the future. I'm here to tell people what is going to happen. The revolution is coming for everyone, and you better get in on it. So let me introduce you to the 4 archetypes of the patient-led revolution: seeker, networker, solver, and champion. I realized in talking about how people connect peer-to-peer that people react in different ways to a new diagnosis, to a new caregiving situation, to whatever they're facing as a health challenge. And I realized that it would be useful for people to be able to have language to describe the role that they play, the actions that they take. And what I want to say at the outset is that you yourself don't have to take on these roles. Don't feel as you're listening that you need to become all of these, that you need to learn the ways of all of these archetypes of the patient-led revolution. You can recruit people to your team. You can look for people in your network who can play these roles. And I'll talk a little bit more about that. So the first archetype are the seekers. Seekers are not getting answers to their questions. They may have symptoms that can't be explained. If they have a diagnosis, there aren't good treatments. And so they go out on the hunt. And what really characterizes a seeker is that they do not give up. The second archetype of the patient-led, survivor-led, caregiver-led revolution in medical care is the networker. Networkers form community. They, if they find something that works, if they find research that's useful, they bring it to the group. They can be incredibly powerful in making noise on social media platforms. Often when I'm talking about the revolution and I'm talking about peer-to-peer healthcare, People say, oh, I know exactly what you mean. That's a hashtag on Twitter, or it's a Facebook group. And I say, yes, and yes, those are the networkers. But there's three other archetypes. The third one, the third archetype of the revolution are the solvers. Solvers are people who, when they see something not working, they can't wait to take it apart and put it back together again. They may be systems thinkers. They may be people who look at the system of a public health response or a clinical trial and say, this is not working. This has to be done differently. A solver could also look at a medical device. I have stories in the book about people who live with insulin requiring or type 1 diabetes who have a continuous glucose monitor that did not give them access to the data that's being generated by their own bodies. And so they hacked into those medical devices and figured out basically how to jailbreak their own medical device and get access to that data. A solver can also be someone who's living with a physical disability, whether it's lack of dexterity or visual acuity. They come up with a hack, an elegant solution. So that's enough about solvers. I love them. I'm not a solver, so I'm a little bit in love with solvers. The last group are champions. This is a group I didn't have in mind when I started writing my book, but in interviews with the patient and survivor and caregiver-led revolutionaries who had been able to really kind of get access to resources controlled by the mainstream, they always named a person who was able to get them that access. And I realized that that's the role of a champion in the revolution. People who, for example, have access to funding, who are able to get access to funding, whether it's investment or foundation funding, or grassroots fundraising. Another scarce resource that a champion can help people get access to is media attention. I think, for example, of Ed Yong and his articles in The Atlantic, and how that was able to shine a spotlight, for example, on long COVID. Regulatory guidance, and access to the halls of Congress and the halls of NIH. People who know how to navigate that, those can be champions for patient-led, survivor-led, caregiver-led revolutionaries. I also realized in writing my book that I was having trouble describing to my colleagues in the C-suite of healthcare, the CEOs of health systems. I worked in the federal government for the secretary at HHS, and I often found that people didn't really understand what I was talking about when I was talking about how many people are suffering and whose needs are not being met. So I came up with what I call the Rebel Health Matrix. And it starts with this x-axis of, on one side, people's needs are met by mainstream healthcare, and on the other side, people's needs are not met. And then I add the y-axis, and this is whether someone is visible to mainstream healthcare or whether they or their group or their challenge is invisible. As you can imagine, the needs not met and invisible quadrant, these are people who are likely isolated. It's where I've spent most of my time while doing field work in online communities of people living with rare disease, life-changing diagnoses, because I got advice early on in my career that if you want to see the future, you hang out with people who are building on the frontier. You hang out with the artists. You hang out with cowboys and hackers and rebels. And that's where you'll find them, in the quadrant where people's needs are not being met and they feel invisible. The quadrant where people's needs are being met, but they're still invisible to the mainstream, is where you'll find a lot of rare disease communities, communities where people have figured stuff out on their own. But there's, that stuff isn't being paid for. That stuff isn't being recognized. And so people's needs are being met, but they're still not visible. Another quadrant, which is really interesting, is when people's needs are not being met, but they're visible, that people at least know that this is a condition that exists. This is something that people need to pay attention because it's a visible, loud coalition. And then the last quadrant is where people's needs are being met, it's visible and recognized. The challenge for this quadrant often is uneven access because of finances, because of insurance coverage. Um, I'm going to talk a little bit about how people move through the quadrants, because I think that's going to be really key for this group to understand. Um, so if a challenge is experienced by a group and their needs are not being met, sometimes a solver will emerge and they'll create a solution. And just the people who are in the in-group know about it. In terms of long COVID, I'll point to the Patient-Led Research Collaborative, which I would characterize as a group of solvers where they used the tools that they had on hand. They used Slack, they used Google Docs to create surveys that at least created the possibility of understanding this condition. I also think of the people with insulin requiring diabetes that I described, where people were able to hack into their continuous glucose monitor and get access to the data. But it's really not good enough if just a small group are benefiting from this innovation. What we need are networkers and champions to publicize the solution, to get the funding and regulatory guidance, whatever it is that people need to scale and bring that product or service to the mainstream. Another way to go is if a challenge is experienced by a group, networkers can get really loud on social media and in the mainstream press. And hopefully then solvers and champions are attracted. They notice that there's this group of people who need help. And they come in and they bring their know-how and they bring their resources. That's a way that I've seen a lot of patient-led revolutionaries eventually move up into that quadrant where they are visible and their needs are being met. What I want to say again is that the patient-led revolution is it has a long history, and I honor the work that everyone here is doing. And I'm going to close by saying thank you for being a health rebel, because you have stepped into this work because you had to. And the work that you're doing is so important because you are teaching everyone about how to respond and how to create space for innovation and invention and community in ways that the world needs to learn from. What I would love to do is hear from you. I'm available on social platforms and would love to hear from people about examples of ways that you've seen seekers, networkers, solvers, and champions in your own life. And if I can be helpful to you as a champion who has access to some forms of power, my goal in life is to democratize access to power and to use the internet and to use all of our voices to lift up the people who need attention from the mainstream healthcare system. And with that, I will turn it back.
Thank you so much, Susannah. Insightful as always, and we really appreciate beautiful slides, slides as well. So at this time, we are going to move into some like a roundtable discussion with some of our panelists. So without further ado, let me go ahead and share my screen again so that we can introduce our panelists. First, I'd love to introduce Ashanti Daniel. Ashanti is a BSN RN who has been an advocate with several chronic illness nonprofit organizations and has shared her story in their events, the national press, and to Congress. Ashanti is a Black woman, a disabled RN, and a single mother living with ME in Southern California. She speaks powerfully not just to what it is to live with a chronic illness like ME, but what it is like to try to get appropriate care as a Black woman navigating the structural racism of our healthcare system. Welcome, Ashanti. I'm also going
Thank you, Amanda.
Thank you. I'm also going to introduce Dale Bolger. Dale is a clinical social worker and therapist and proud, openly polyamorous, queer, gender, nonconforming person. They've spent most of their life experiencing microaggressions and unlearning the cisnormative and heteronormative messages that they feel constantly tell us we are defective, broken, or unwanted. They believe that we are all, and I quote, fabulous, vibrant, and deserving of all the gifts the world has to offer. I love that. They became a therapist to share what they've learned, bring healing and advocate for queer, trans youth, young adults, and their families while working for social justice and full inclusion into society. They pride themselves in providing a safe, affirming space so everyone can collaborate to create and implement a roadmap to recovery. Welcome, Dale. And I'd also love to introduce Amy Mooney. Amy is a private practice occupational therapist who specializes in providing therapeutic care via telehealth to individuals with chronic conditions involving post-exertional malaise and post-exertional symptom exacerbation. Amy's pacing for PEM guidelines and therapeutic strategies have been featured presentations at national and international conferences, continuing education programs for medical professionals, and patient advocacy webinars, like this one. As a caregiver for a loved one with ME/CFS, Amy understands firsthand the challenges individuals and families experience seeking appropriate care. And as a fun fact, Amy is a returned Peace Corps volunteer. So welcome to our 3 panelists. We will have additional 2 panelists that we will introduce after this roundtable discussion, but for this portion, we wanted to do a roundtable discussion with our providers and our care team and ask them some key questions today. So first of all, welcome, and I think we'll just go ahead and jump into the questions if that's okay with you. So the first question is, who coordinates a care team? Is it the patient? Is it the caregiver, the primary care provider? Where can we even start? And Amy, would you like to take this one?
Sure. Thank you for including me on this panel. This is a really good question because I think it is, there is no clear answer. I think it's everybody above that you just mentioned, and it's also people that come out of the woodworks that can help to be advocates for this particular individual that is needing care. So if I guess there's 2 different avenues that I guess I want to just point out for managing care. One might be managing care for an individual that needs medical intervention, medical support. And the other is for our pediatric population who is really needing educational support also, as along with their conditions, with their post-exertional malaise, with their worsening of symptoms. The pediatric community, I think, often gets overlooked in this field, and there is usually a team at schools that are ready to come into play, but they just don't know how to support patients or kids, students. So sometimes for that particular population, grabbing one of the advocates at the schools, a social worker, an OT, somebody that is trained in a medical field, would be the start to being a medical care coordinator. But they're coming in with no knowledge of complex conditions. And they also have the piece that they're trying to keep the education as the goal. And that's true, but a lot of these kids are so medically fragile that they need to be able to understand what kind of stressors and strains that will be happening. And so how to place the educational goals on a back burner while the medical interventions are happening. But for the first group that I mentioned, the people that are really needing medical complex care to coordinate, this piece is often left to the patients, who then are the most fragile to coordinate that care. They need the most help for that. So what I do with a lot of my patients, with the individuals, is to grab onto a couple family members, or even to ask them who are their most supportive friends that might not have been their closest emotional support, but who would be somebody in their life that would be most trainable, who would be most willing to learn, and add them to our OT sessions. So I've done recordings of my OT sessions with my patients just so they can share it with other people in their groups. So I think, like, for patients to learn that by stepping outside a little bit of their comfort zone and asking people that they normally wouldn't ask for help with, they then widen their network just a tiny bit. So finding people that are a little bit more open to learning about their symptoms and how their lives have been really affected by this complex disease.
Thank you, Amy. And definitely stepping out, I hear you saying stepping out of your initial network and being able to be creative maybe a little bit with who you're able to ask and see who might be willing to step up and learn more about this disease often and become an advocate on your behalf. So wonderful. Ashanti, what about you?
Typically, I would say it would be the primary care provider. However, it is perfectly acceptable for a patient to coordinate their own care team, although that can be a very daunting task for patients, especially if they're dealing with complex chronic diseases. A social worker or a clinical case manager, who is typically a registered nurse, can also coordinate the care team. If a caregiver has written authorization that meets Healthcare Insurance Portability and Accountability Act, better known as HIPAA, or has been designated as a healthcare proxy, which the healthcare proxy piece wouldn't come into effect unless the patient is incapacitated. However, signing written authorization that is HIPAA compliant would allow them to have access to participate in the care, see medical records while the patient is still able to speak for themselves. So there could be a number of people that can help coordinate the care team. And it's really important, I feel, to have multiple people, because oftentimes dealing with complex chronic diseases is complicated. And so you need multiple people working on this to ensure that patients get the best care.
Yeah, so I'm hearing multiple people, maybe pulling from creative different places, whether it's provider and even stepping outside of that initial circle. Dale.
Thank you. I'm really in a complete agreement with what the earlier panelists have said, and I appreciate that. I do agree that the professional agency should ideally be the one who is setting up the team. However, in reality, that doesn't happen enough, and it often falls on the client or the patient or their immediate support system to set the team up. And once the team is up, I really think that in order to be successful, that it should be a collaborative effort amongst everybody who's involved, with keeping the patient's needs at the foremost in the center of the conversation. But again, everybody should be equally working towards that collaboration.
Thank you. So next question. As a provider, what do you love to see your patients come prepared with? What helps when part of a care team? Ashanti, would you like to start?
Okay, here I am. I was muted for a second. I would say, as a registered nurse, I think that, of course, medical records, if this physician or whatever provider has not seen this patient before. Also, I think it's critical to have questions for the provider that allow the patient to assess whether this is the right provider for the patient, because of course, when dealing with these complex chronic diseases, not all doctors can provide care for us. Some doctors don't believe us. Some doctors just don't have the tools and knowledge. So I think it's really important for patients to also be evaluating the providers to ensure that this is the right provider for them. Any other information that they have regarding their illnesses, their concerns, sometimes I think it's important to prioritize what is most important to the patient. Like, if there's a specific symptom that is affecting them more than others, I think that's important to mention. And I think that pretty much encompasses some of the really important things that I'd like to see a patient come to their appointment with. But as a nurse, our job is to advocate for patients. So it is also our job to ensure patients have the tools to advocate for themselves. And that's why I am talking about the questions that the patient needs to ask the provider to determine whether this is the right provider, because you don't have to stick with a provider. Just because you want to see them doesn't mean that you have to stay. You can fire the provider. And I hate to say it that way, but that's the reality. I think a lot of patients don't know and don't understand that they are also essentially interviewing the provider to decide if this is the provider for them.
Such a great point. I know something I hear a lot from our community is feeling so helpless and lost, especially when you're in the provider's office, which can feel very intimidating. But what a great point you're saying, that you are in the driver's seat and that you are also interviewing them, and you can decide if they're a good fit for you, not just if you're a good fit for them. Great point,
Exactly.
Ashanti.
Thank
Gail.
Thank you. Again, I really want to agree with what you had just said earlier, that the patient or the client, I really appreciate it when they come in with questions, after doing their own research, know what they're looking for. I know it's not always possible, but as a care provider, it always makes my job easier when the client knows what they want and what it is they're looking for. And if they don't have that information, a lot of times I can ask leading questions with them in order to try to figure out what it is they're looking for, in order to spark the questions from them to really dig in and find out what their needs are. The more prepared the client or the patient is, the easier it is, I believe, on the whole care team's job on coordinating the care.
Wonderful, thank you. And Amy.
Well, as an occupational therapist, I am wanting to know what limitations, what are the barriers that are most interfering with their functional performance? I want to know the details of what is making this activity of daily living not able to be performed. What are your core occupations? And this is what an OT does, is we look at an occupation, you're a child, you're a friend, you are a gardener. Those are your occupations. It's not, we're not trained in job placement. We are actually looking at what your jobs of daily living are. So for your ADLs, your occupations of daily living, what are the barriers that are interfering with your daily production? Are you having difficulty because symptoms with say your heart rate is unmanaged, or you're nauseous, or what are the primary symptoms that you are feeling? I want to know that with my patients. I want to find out what pieces of their day are being stopped, and then I want to break down and figure out how can you do that activity with a different maybe outcome in mind. You don't need to brush your teeth. You can maybe use mouth strips. You don't need to stand at the sink to do an activity. You can do things seated. You can do things different. There are no rules. And so I want to go through and just pull apart those activities that they want to and need to do in their daily living so that they can do it better, so they can do it without more symptoms. And with this disease, which is ripping apart all of their aspects of their occupations, I want to start adding things back to their day so that they have more predictability, more control, more symptom management, and it's not going to take away their symptoms, but it's going to at least lessen the symptom intensity. And that's where I feel like these individuals get more meaning of their day. You know, they've done these little things and they've checked them off their boxes, and they haven't done everything that they wanted to do, but they at least got the top 2. And that's what I want to give individuals, that piece back to their daily living, and then figure out how their environment can support them. I want to teach them things like, you know, if you look at your weather app, when is a storm coming? When is barometric pressure changing? When are seasonal allergies going to be more intense? Are they morning or afternoon? Well, then let's plan for when you do a certain activity, because, you know, in the afternoon, you might have more change, you know, more environmental influence for your symptoms. So that's my piece, is trying to understand what the barriers for function are for that individual, and then start strategizing with them.
Great. And we have an interesting question in the chat I'd love to share with you. And this is a great point. Carolyn says, this discussion assumes that there is a provider, that there's a caregiver, that there's a nurse, that there's maybe a therapist of different kinds. So what about when you can't even get that far? What do you do then? And we will start with Dale.
The internet is generally the best place. I have found, assuming you've got access to the internet, in order to begin researching and find the person that you need in order to get started to develop your team. If the client or the patient doesn't have the spoons to start that process, then hook that process up to someone else that you trust who has the ability to do that research for you, you know, a friend or a family member, you know, someone who can advocate on your behalf until you're at the spot where you can advocate it yourself. It really is difficult if you don't have a system in place in order to create that system. It's a really big struggle, and that struggle can be enhanced or made worse by geographic restrictions. You know, the more rural of an area you're in, the harder it may be to even find a service provider, much less be able to create a service team. So there's a lot of barriers that may need to get addressed in order to get to the spot where they can start working on the issues.
Ashanti or Amy, do you have anything you'd like to add?
I just want to add something very brief. I agree with Dale completely, and the internet is a great source. Another source, in the event that the patient has insurance, they can contact their insurance company for assistance in identifying a provider. Now, I do want to acknowledge that, of course, spoons are hard to come by for people with complex chronic diseases. So you would have to, I would say, pace yourself would be the key when looking for a provider. You know, sometimes these insurance companies have where you can go to their website for information, or you can call in and talk to an actual person, and you have to decide for you which takes the least amount of energy. And that's somewhere where you can start, is with the insurance company, identifying what providers even take your insurance. And that even applies for patients who are on Medicaid. Medicaid has a list of providers that are contracted with them, and you can start there to get the information. Although I do acknowledge that with the physical challenges that come with these complex diseases and the cognitive challenges, that could be a really daunting task. So if there's a friend or like anyone who can help with that piece, because that piece does not require written authorization to find out like who the providers are that are contracted with the insurance.
And I guess I will add that some of the education strategies that are out there can be utilized for, you know, figuring out, like, just going again on my functional performance pieces, you know, how are people going to start learning what they need to do for their daily living? You know, I'm sorry I keep on pushing this point, because I think, like, if somebody doesn't have a care team in place, just making subtle changes to how they're able to manage just, you know, their self-care activities is a start. Just understanding, you know, you're not going to maybe have unlimited opportunities with an occupational therapist or a nurse practitioner or somebody to come and help you manage your medicines and things like that. But if you can understand what your symptoms that are most interfering and most debilitating are, at least to take off some of that intensity of your symptoms. And it's absolutely a limitation to our medical field in general, is that not everybody has access to the same quality care. And I think we've lost a lot of accessibility with COVID changes, that, people aren't able to get telehealth services like they once were. Doctors on demand can't answer a call, and they charge out of pocket, so things have changed and accessibility has changed. But I think if you can start noticing and writing down and keeping tabs of some of your patterns of symptoms, that at least can start with your own unraveling of your own symptom presentation. Because I think when people get so overwhelmed with all of their symptoms, they have a difficult time peeling back what some of the more easy solutions may be. It might be, putting your feet up so that you're not having gravitational changes, you're not having POTS symptoms as bad. Just doing some things that maybe feel a little bit more, not easy, but just more simple tasks to change your own setting might be ways just to at least checking in on yourself more often. How does this type of activity make me feel? And being your own little self-reporter might be a way to do your own healthcare without necessarily a whole team of licensed providers available.
Great point. So it sounds like a common thread in a lot of the answers we've heard you all say is really being creative a little bit in the different resources that you have. So even though maybe you don't have a full care team, I hear, well, you have the internet. If you're on Zoom with us right now or on YouTube, you have the internet, and finding the resources there, as well as on your personal life. Amy, you're talking about your ADLs, your activities of daily living, and how you can make these small steps, maybe a little bit at a time, to make those improvements and be able to maybe move into a position where you can advocate more for yourself, where we can find those that provider team you can start to build. But it definitely is such an overwhelming task, right, to start with, if you just became sick. So we'll just finish with one last question before we go on to our break and return. So I guess that would be, given this discussion, if you were to come across somebody who just got sick, what would your number one piece of advice be for them? If you would
Mine would be,
or Amy, go ahead. Yeah.
sorry. Mine would be, don't push through. Take time to heal, rest, recognize your patterns, because how you do things physically is different than what your cognitive symptoms look like, and your social emotional symptoms. They all are different buckets of symptoms. And I want people to stay present with how these activities, does something physical make a certain group of symptoms worse? Walking around the block or even standing up to use the bathroom makes your symptoms worse than having a conversation with a loved one. So I want these individuals to start looking at their symptom presentations as somewhat, I know it's really overwhelming, but there can be patterns by certain types of activities, certain stressors. And so I would teach newly, people that are new in this particular diagnosis to really start identifying some of those things, but just rest and let your body heal for right now. You're not going to get better necessarily in a short time window, or it will take time, but your best chance of healing is by resting.
Go ahead, Ashanti.
Oh, I didn't know if you're going to call on me or not, so I just unmuted. But I would like to add, basically piggybacking off of what Amy said, do not push through. I cannot convey that enough. Try to learn how to pace. That is so, 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 so important, especially early on, because you have a chance to end up with less severe symptoms if you pace and don't push through in the early time period of being ill. And in full transparency, I, at almost 8 years with this illness, have a difficult time with pacing. So it's not easy. I'm not going to sit up here and pretend like I'm the expert of pacing. I am not. But I encourage you to try to be an expert of pacing, because I find patients who have been sick way less years than me, 1 year, 6 months, or whatever, and they have pacing down to a science. That isn't my case, but I do absolutely recommend that you pace and that you listen to your body. Whatever, just like Amy said, like pay attention to symptoms and stuff. It is really important. And also be aware that when you are dealing with these complex chronic illnesses, you may have symptoms that you have never experienced in your life. You may have symptoms that you can't even really describe, right? But pay attention to those. And I don't care if someone says, oh, you're making it up or you're crazy or whatever the case, don't believe them. Don't allow anyone to gaslight you. And most importantly, don't gaslight yourself. Believe yourself, because if you don't believe you, then how can you help yourself? You just can't. So I think that those are really, really critical things. And one other thing I want to mention is to connect with other people in our community, because the patients are amazing. And there are quite a few of us who are willing to help others, based on whatever spoons we have available. But we have a wealth of information. There's some of us that have a bunch of information about one thing and, whatever the case. But I think it's really important. And I don't want to end this without mentioning that I realize that access to care is problematic at the very minimum, especially for patients who are, minority, female, queer, whatever the case, right? I understand that. But this is about you taking care of you. So this is what I'm speaking of, is not necessarily in regard to accessing healthcare when you're, first ill.
Thank you, Ashanti. And Dale, any last final words of wisdom to add?
I don't know about words of wisdom, but I definitely agree with what you two are both saying on that. And I'd like to add to that, as well as reaching out into your community to start finding people that you can support you through the process, is don't forget about the self-care. Do the things that help make you feel better, the things that keep you rejuvenated, refreshed, the ability to go, and give yourself grace. Give yourself the time to relax, the time to heal, and don't let the society that we live in dictate your schedule. Let your body dictate your schedule. Ask for what you need in order to take care of yourself.
Can I add one more little piece?
Of
I
course.
just, I want to reiterate that pacing is work, and it is not doing nothing. And a lot of healthcare providers will say, you need to work yourself back. You need to do something to get yourself better. So that mentality does not identify that pacing itself is work. It is so much work. It is so hard, and there is so much effort to being in a body that does not function. It does not function efficiently. There are systems that are working against you inside of you. So I just want to make sure that the patient community, the individuals that are experiencing this chronic disease, realize that by that comment of just pace it, just don't push through and don't pace. That does not mean we are saying you are not working. You are. So I want to give that call out to everybody that feels like they are being judged. You aren't. So take care and have grace with yourself.
Wonderful point. Sometimes being able to rest is actually the most difficult thing when you feel you have so many things that you want to do. So no, great point. So I want to make sure that we have about 10 minutes for our break. So we are going to move into our break time. Just so everyone is aware, we will be returning at 10:05 a.m. PT or 1:05 p.m. ET. So 10:05 Pacific time, 1:05 Eastern time, or you can do the math if you're in between. I just really want to thank our panelists so far. When we return, we're going to switch from our panelists being our providers to our panelists being our caregiving team, or excuse me, our caregivers and our patients. So similar questions, but now we're focusing on the other side of the team. And I also just want to remind everyone, if you're not able to return, or you had questions for this amazing panel group and for our wonderful speaker, Susannah Fox, that we will be having breakout sessions later throughout the day. The first one is at 11 a.m. Pacific time, which is 2 p.m. Eastern time. And the panelists that we just spoke to, Ashanti, Dale, Amy, as well as our featured speaker, Susannah, will all be there to answer just your questions one-on-one. So I encourage you to return for that. And I also encourage you to return in about 10 minutes for the second half of our main event. So again, thank you to all of our speakers and thank you to everyone here. And we'll see everyone back in about 10 minutes. Wonderful. Thank you. So welcome back, everybody. We're going to get started with the second half of our event. And this portion is speaking to our panelist speakers from the caregiver and patient perspective. So I would love to introduce our one of two panelists for this section. The first person we have is Sanna Stella. Sanna was diagnosed with bacterial bronchitis in 2014, which turned into debilitating fatigue within 1 month and led to seeing all kinds of specialists at Northwestern Memorial Hospital in Chicago. She was lucky to be diagnosed with ME/CFS early, though the hospital could provide no treatments. She moved to Germany for a year, and she was able to see another internist who was mentored by the first physician to write a book about CFS in Germany. She tried various supplements, IV ozone therapy, and participated in 5 clinical studies at Stanford University, DePaul University, and the post-infectious intramural NIH study. Over the last 9 years, she slowly but steadily improved, completing 2 online degrees, mostly reclined in bed or on the sofa, and now she's able to work full-time as a therapist in Chicago. Welcome, Sanna. Our second panelist is Miss Emily Taylor. You might be familiar with Emily Taylor because she is actually our president and CEO of Solve ME. She brings over 2 decades of unwavering commitment and expertise to her role here at Solve. With a career deeply rooted in health policy, grassroots advocacy, and community empowerment, Emily has dedicated herself to advancing medical research and patient voices in the realm of ME/CFS, long COVID, and other infection-associated chronic conditions and illnesses. And on a personal note, Emily's mother became ill with ME/CFS in 2008. Emily was her full-time caregiver from 2009 to 2011, and her mother was finally diagnosed with ME/CFS in 2012. Over the past 15 years, Emily has devoted her life to this cause, both in her personal and professional life. Welcome, Emily. So we're going to jump right into our discussion so that we can maximize our time with our questions. So first question would be, excuse me, would be medical coordination and service providers, bridging payments and data, communication, and care between multiple providers in different specialties. Where do we even start? Emily, I'll go ahead and start with you.
Thank you so much. It's a pleasure to be here, and thank you, Amanda, for your moderating. I am so humbled to be on a panel with Sanna. I love working with you, Sanna. I am so thrilled, and I'm excited to hear what you have to say. My experience with running a care team was on behalf of my mother, who is a patient with ME/CFS. And it was, as you and many of you know, it did not come with a manual. And so all of those different pieces you described were very overwhelming. I did a lot of research, but ultimately I found what really was the most beneficial element for me personally was creating personal connections with the different service providers. So they knew me, I knew them, we had a relationship, and we had that trust established. I think that was the key element, the trust and two-way dialogue. Not just a one-way dialogue, but it had to be a bi-directional partnership in that dialogue and how we coordinated together. And I just want to reiterate some of the elements that were shared by our previous panel, that we had to fire some folks. We had folks that were not a good fit on our care team, that either didn't work well with other practitioners or didn't work well with our family. And sometimes we had to move on. So I think it was a combination of having the ability to be a full-time healthy caregiver, to stop everything, to quit my job and become a literally full-time dedicated patient care coordinator for my mother. And it was a full-time job, absolutely. And that was a privilege that we had, and not everyone has. So I just really want to highlight one of the elements that was recently illuminated to me as a good service for folks who might not have the resources or have the ability to just become a full-time care coordinator is virtual assistants. That's something that's come up very recently as a low cost and really surprisingly effective mechanism. They even have virtual assistants that are specifically trained to be HIPAA compliant and can coordinate with your doctors and care teams for you. So I think I'll say that the relationship building was what got me and my family through that time period, but now there's more options and more technology that can be brought to play that hopefully will make that process easier for folks moving forward.
And Sanna.
Well, so I guess I thought maybe also I could give, just to introduce myself a little further, just a little more background on kind of like where I was initially when I was starting to really look for that care, because right now it looks very, very different. And so, yes, when I initially got sick, I really was bedbound for a long, long time. And so that's another barrier to actually finding a care team, because you have to be able to get there. So there were times when my husband basically said, we have to cancel this medical appointment because I can't get my wife there. So, you know, that already, just being able to get there physically was one barrier initially. And then I think what Emily had mentioned somewhere is that, like, that relationship to, if you don't have a provider who doesn't even really believe you, I feel like then it's like you're doomed from the beginning. So I would say just you have to like keep trying. You have to keep looking for that. We have to start with being believed that there's something wrong, that these symptoms are real, and the personal relationships sometimes unfortunately are really key for that. So I had a lot of friends who were referring me to all kinds of people, and I was going to all of those things, trying to find somebody who would be helpful. So one of those was an internist who, I think because of the personal connection, somehow did believe that there was something wrong, and that she took it on herself to really, send me all around the hospital to figure out what was wrong. But it had to start with even believing that something was wrong, right? And I think one of the things for her, there was the personal relationship, but then she also was the only medical provider who, when I described things, right, you're sitting in a chair, you look okay. So she actually said, well, let's see what happens. So she asked me to walk to the copy machine with her, so she could see sort of firsthand what would happen. So I said, sure. And we started walking towards the copy machine. I did not make it to the copier. She suggested we go back because she could see how hard I was laboring just halfway towards the copy machine. And so I think that really, the personal relationship plus just seeing actually, sort of seeing it in action. Somehow I think that did help really sort of, help her believe that these symptoms were correct, that I wasn't just talking about something. She could see it physically in front of her, how hard I was breathing, how, hard it was for me to move my foot just that little bit. So I would recommend, I don't know if, if people are with a provider that they feel like maybe they can work with, to see if they can say, can I show you? Not just tell you, because I think the whole like seeing is believing, and sometimes might do, something that really, when we just sit there and talk and we look just, sort of fine, it's easy to kind of go, or minimize it, but when you see somebody laboring to move, I think it can be very different.
Great point. And this gets me thinking. I know Emily mentioned having an AI assistant.
Or paid virtual assistant, which are
paid
very low
virtual
cost.
assistant. Okay. And Sanna, you're mentioning what do you do when you can't see in that moment that you're physically sick? And I know something that a lot of people are using now, this touches on, is technology, right? Different ways to track things. And is there a way that we can see that we're sick and show people? Or Emily, to your point, having a virtual assistant. So what role do you see technology playing in the future for care team coordination? Which I know is broad, right? That's a huge, but just for you, from a patient perspective, from a caregiver perspective, what are some of the things that are standing out to you as some of the key tools or things that people can look towards to start to utilize in their personal care? And whoever wants to go first.
Yeah, I'll jump in. I am very excited about this area. I think it's a really promising developing field. We are already seeing apps like the Solve Together app, like the Visible app, like Rhythm there, and for long COVID, there's quite a few apps out there that all essentially do one of three things. They either coordinate and consolidate your symptoms so that they are easily displayable or transmittable, the things that connect to, like, for example, wearables, where you can see your heart rate and your pulse and your O2 ratings in a very simple, easy to design area. That's one element of technology. So like data gathering and data storage. I remember, and some of you on the call may remember, those packets and packets of medical records. And every time you went to a new doctor, you had to print or copy all of the medical records and bring them in a big file that was sometimes, inches thick to your new provider, and then have that whole dialogue, and then they would have to sift through it. And now that's all digital and much easier, faster. Things like MyChart have made doctor coordination so simple when it works, being the operative word, when it works. Sometimes it can actually be a barrier or a challenge. In fact, with the care providing for my mother, some of our providers do take digital options and some do not. So we're kind of in this hybrid place where we still have some paper records and yet some are digital as well. And I think the folks where the digital elements have come in are more effective, yet can be so much more frustrating when they fail, when you can't get a record, when you can't get that data that you need. And especially now, because we have so many different electronic health record systems in the United States operational, if they don't play nice together, it actually creates more hazards. So I guess it's a long way to say I'm very optimistic about where technology is going. I don't think we're there yet. I think we have some ways to go, but apps, symptom management, and the last piece I'll just mention is data sharing for research. This is another area, again, that I'm very excited in. A lot of our patients, and my mother included, and Sanna included, have put your body on the line to be an object of a study for research. And doing that virtually instead of having to go to a clinic, which taxes our patients so severely, I think is really exciting as well. So those are the three areas of technology that I'm really looking forward to seeing more, and cautioning that they're not always operational, but when they are operational and working at their peak best practices, they can be really, really helpful.
Absolutely. And I know just within the population that we talk with, there are people that love the Visible app. There are people that love the Solve Together app. It's kind of, it's unfortunate because you're energy limited, but sometimes just trying things out, especially if you can have a caregiver or someone else help you through the process in the beginning to figure out, once you learn the language and the ins and outs of that particular one, but being able to hopefully find one that works for you, because a lot of it is preference. And to Emily's point, right, we're still in the process of getting there, but hopefully you can find some utility and some help with where they're at right now. Sanna, what about you?
Yeah, first, so Mimi, I see your comment. I will try to slow down a little bit. Uh, she asked the speakers to try to speak a little bit slower, so I will try. There's always so many thoughts going through my mind, right, as I'm listening to the question and then Emily's response. I think the first thing that came to mind is to really, use the whatever we have available in terms of technology creatively, even if it's sort of the reverse of what it's designed for. So one of the things, for example, is I had a Fitbit at some point, and I could set it to, really a goal, which for me was like a warning, a threshold. So I would use it in the reverse rather than to try to hit the whatever it was at that time, I think 1,500 steps or something like that. I had it set so that I knew when I hit that, I'm like, okay, now I really need to pay more attention to whether, these next steps are necessary. So I used it as kind of a warning system rather than this motivational keep going kind of thing, right? So I used it, I felt like in the reverse of what it was designed for. Oh, I had another thought that now escaped me. Well, technology in general, I think for me, yes, has been absolutely huge. I got sick 9.5 years ago, so there was not as much telehealth and all of that available then. But I used it really to, because there's a physical health, but I think also them as a therapist, I believe our mental health is also very, very important. It always can be used to, optimize our functioning physically too. So for me, I use the technology a lot to be able to connect with people, like connect through the internet with other patients. Also though, I completed 2 online degrees from bed when necessary, and in various places of the home, but I gave a 20-minute presentation laying flat in bed. I couldn't even really be propped up much. So I used the technology to be able to do something that was still meaningful, to connect with others. Just in any way that seemed like it would somehow be helpful, right? Both sort of mentally and physically. I think it can be helpful in both of those ways.
Right. And I hear you both saying using technology for what you need. Like you said, you're using Fitbit and it wasn't necessarily for the function that it was intended, but you found a way to make it work for you, which is, I think, absolutely key right now. And with all of these new and up and coming different, some like the Visible app or Solve Together that are specific to this disease space, and some that are not, but maybe you can find a way, like you said, where it gives you warnings before you exert yourself too far or things like that. Great point.
Actually, one more thought that I just had. So, I do have now an Apple Watch too that does track heart rate variability. And I know the NIH study has found differences in heart rate variability. And so I don't know yet whether this will be useful at some point, but I have a lot of data over, several years now. And I know my heart rate variability is less than half of what anybody else I know has. So I can see that there's a difference. And I'm just going to sort of store that data for now because I do feel like it may be helpful at some point.
Great point. So I want to switch gears just a little bit. We have a question in the chat, and it says that they're looking for a new primary care provider because the previous one didn't believe them. And now his notes are in their Epic My Chart. How would you correct that? Should they write a doc and have it included in My Chart? Would this make future doctors skeptical because they complained? Or more broadly, what do you do when you have, right, you're trying to correct something in your chart that you know isn't true? How would you, as a patient or a caregiver, address that?
Great question, Amy. And I've dealt with this particular situation before with some inappropriate medical coding and terminology that was added to my mother's chart that actually did, and I believe truly influenced the quality of healthcare that she received negatively because those previous doctors had put in some problematic language into her chart. But this is where it's the positive side. Just a reminder that you actually, as your bill of patient's rights, as your rights as a patient, have access and control over your record keeping. And I'll just drop a link in the chat here about HIPAA compliance for the HHS and guidance on what you can and can't do with those charts. So you can actually petition and submit that pieces be removed or certain pieces be added, and you need to work with a healthcare professional and nursing practitioner to do that, but that is within your rights, and that is a possibility. So I'm really glad, Amy, you brought up that point, because I know it can feel like you're stuck with some of those charting and notes, whether or not they're still accurate or perhaps an inappropriate diagnosis you've moved on from, but you can always update those and change those. That is your right as a patient. So I'm really glad you could flag that, because I think that's a bit of information that most people don't understand. And I'll also just add in a moment, the patient's bill of rights, which I think is key, and it can be different areas, but this is the patient's bill of rights from CMS. And I think that is a critical tool for every patient and provider and caregiver to have in their toolkit, to be aware of and understand exactly where your rights are, and flexing them or enforcing them when is necessary.
And Sanna, do you have anything you'd like to add?
I guess the first thing for me that came up was sort of like my brain is used to, I think, sort of the constant pacing decision making. And I guess so. I haven't had personal experience. I've worried about, I have been taking low dose naltrexone for probably 8 years. And naltrexone is something that is usually used for alcohol and substance abuse. So for a therapist to have that on their record, I do feel like, I don't know whether there will be some probably medical providers who would not understand the difference between the regular dose and the use of low dose naltrexone. So I've kind of worried a little bit, a moment here and there, whether it might be misunderstood. But I think for me, it was something where I'm like, well, okay, I'm going to set that aside. I can't control, so back to the pacing, it's sort of like, I would have to decide whether this is something that I'm going to put my energy into fighting, whether it's relevant to my care, or whether, I will just address it when I meet a new provider, when it is relevant. And yeah, so I think I might have to weigh whether it's important or not, depending on the situation.
Right. You only have so many spoons. So being able to weigh what to fight, what not to, but also knowing you have the power to fight. It's within your rights. You have the ability to know what's in your chart and decide what stays in and what is removed. So we only have a few minutes left, and I just want to ask one last question to you, and hopefully get like a minute response or so before I know we're out of time. But I'd love to know. So we've got a patient and we've got a caregiver, right? And it's this perfect team that always works well together, no issues, seamless, or maybe not. What happens when, as a patient, you want something, and as a caregiver, you want something else? How do you navigate that tension or those disagreements?
Oh boy. Sanna, is it okay if I take this one first? Yes, I'll say two things about this piece. The first is be prepared. I think it's really important for a patient and a caregiver to have difficult and clarifying conversations first. Make the time to do them early, so that when you are in the doctor's office or a medical emergency or some other kind of situation, you already know what the boundaries and intentions and desires of the patient are. So that's the first thing, is have those questions first, or have those conversations first, and have them and have a clear, even if you have to write it down, sometimes, I mean, it's an agreement, right? That, and I've had this, I'll bring up some specific examples. My mother and I disagreed on a potential treatment opportunity. I thought that the risks were too great. I thought the side effects could be really damaging, and I was scared about my mother going on this pathway of treatment. And yet, it is my mother's body. It is ultimately her bodily decision, what goes and what treatments, what goes into it, what comes out of it, what treatments that she wants to try. And she ultimately is the decider. So I think it's important for patients and caregivers to have those conversations early, so in advance what the intentions are. So for example, we didn't have that argument in front of the doctor. We didn't say, no, not a good treatment. Yes, a good treatment. We didn't argue in front of the doctor. We talked about it ahead of time. So that the time we went to the doctor to discuss the treatment, we already understood that it was my mother's intention to do it. It was her decision. And the second piece is make space for both opinions and recognize that the caregiver, especially a family caregiver, needs to be heard and have an opinion, yet the decision is ultimately with the patient because it is their body. And so I think for the patient side, the patient should acknowledge that their caregiver has feelings, has thoughts, has opinions, and make space to hear those feelings. And it's up to you whether you incorporate those opinions or feelings into your own decision. And yet the caregiver needs to recognize that it is the patient's decision. And I'll give another example that a little more difficult one. My mother was hospitalized recently and was incapacitated. And so I, as her caregiver, became her designated medical officer in that moment when she was unable to make decisions. And they asked me, is she DNR, meaning do not resuscitate, which is an important decision that, again, you should prepare ahead of time. And because my mom and I had that conversation previously, even though my instinct was, of course, I want my mother to be with me forever. I would never I want to do everything possible to ensure that we have as much time together as possible. But again, she was very clear, I prefer DNR and that is my decision. So I had to, even though my personal feelings may have been conflicted, express what ultimately is her desire. And again, that's why I want to emphasize having those conversations beforehand, because what if you don't know? What if something happens, there's a medical emergency, and as the care provider, you're suddenly left with a decision and you don't know what your loved one would have wanted? That is a very tough decision to be as a caregiver. So I emphasize there's some really good guides. I'll drop some links in the chat for how to have these conversations, but have them early and have them before the medical emergency. And again, acknowledge the space to have the conversation, but ultimately acknowledge and always defend it is the patient's right and decision at the end of the day.
Thank you, Emily. Sanna, in our last minute or so, sorry, I want to be able to have more time, but would you like to add anything?
Yeah, just real quick. I guess I would just say, yeah, if there's one advocate or a provider who really isn't working in the way that you need, just to keep, maybe it's not the time to fight that person, but put that energy into finding somebody else who will advocate for you the proper way and provide what you need. So just don't stop when you hit somebody that doesn't work for you. Just keep looking, move on maybe.
Yeah. At what point, when does that caregiver and that team maybe no longer fit if you can't overcome those disagreements? A great point. Okay, Sanna and Emily, thank you so much for joining us today. I know we have more questions in the chat. I have more questions for you too, and I'm so excited that you will be returning for our second panel later this afternoon. So I just want to thank you for joining us today, and I'm going to go ahead and share the screen again. There we go. Just to let everyone know where we're at now on our final announcements before we close. So just a reminder again, we have 2 breakout sessions that are happening later this morning or afternoon, depending on where you are. So at 2 p.m. Eastern time, that is 11 a.m. Pacific time, we'll be going over a more intimate closed door session with our speakers, Susannah Fox, Ashanti Daniel, Dale Bolger, and Amy Mooney. This is a non-recorded session and a great time if you'd like to come and just ask your questions, get more one-on-one answers, and hear more from that amazing team. And from our panelists that we just heard from, Sanna, Stella, and Emily Taylor, if you join back at noon Pacific time or 3 p.m. Eastern time, you'll get 45 minutes again to be able to chat with them, ask your questions, and learn more. And just a couple quick announcements. Solve is having a Bid for Hope, an online auction for World ME Day on May 12th. Here's a little bit of information on it, but we welcome everyone to join our online auction. that will kick off on Monday, May 6th and run through May 13th. And I know there's really cool, actually, different things that are being auctioned off. So we invite everyone to check that out. And along the same lines, May 12th, World ME Day. You can find more information at worldmealliance.org/worldmeday. And last but not least, we invite everyone to join our online community. We're on all these different social media platforms, and you can always join our email listserv and learn more about events like this and Advocacy Week, which we're closing up now. So again, I just want to thank everyone for joining us today. This was a wonderful main event for our EmPOWER ME of 2024. And as we close up our Advocacy Week 2024, again, thank you to all of our advocates, all of our patients, our caregivers, our supporters, and our teams that made this all possible. So thank you all, and hopefully see you during the breakout panels.